Greetings. This is Graham working with you on the hip op case. This case was developed with Julie Katie Ray and Dr. Kanoja, who, at least at the time, was director of orthopedic surgery at School of Medicine at Hopkins. So the idea here is to explore the hip and knee replacement process at the hospital, and to try to find improvements. There's information here on the actual surgical process. There's information. You got some images here that show what's entailed in the knee and the hip replacement. This is a total hip replacement, and these images are used with consent. There's also some information on the patient demographics. So Paul Kanoja published with some co-authors this paper in 2019 that showed that BMI is a significant predictor of the time that these surgeries take. And his concern is to complete, I think, 6 surgeries. He's in an academic hospital setting, and achieving 6 surgeries would be, something that they want to go after. In private practice, because there's not a teaching element to the surgical process, up to 8 surgeries are possible. But they are trying to teach as they go. There is also some information on gender and ethnicity here. Neither of those were found to be predictors of surgery time. So the surgery in a nutshell is you've got, for the purposes of this case, this Hipkins hospital, fictional hospital, and there's 2 groups of 2 ORs. And we're scheduling 6 patients each day, and we're agnostic as to whether they're getting hip or knee replacements. The surgeries are roughly the same length and time. The surgery center opens at 7:30, and we're scheduling folks to come in every 90 minutes. And there's a 9.5 hour day, which ends at 5 p.m. And the challenge here is, can you get to 5 surgeries? And 6 would be ideal. And so that's our challenge, to figure out if there's some adjustments in scheduling or other concerns that would allow us to achieve that target. If you don't get to 6, then the final patient is not going to be started and would get bumped to the next day. So there's dissatisfaction and the other disruptions that follow from that. There are differences in the surgery time, and this comes from Dr. Kanoja, showing the procedure time for underweight through morbidly obese. These are BMI-based numbers. So you've got the process mean and the standard deviation. You can see that for the morbidly obese, procedure time is the highest, and the standard deviation is also, so it's getting more and more variable. Special equipment may be needed, lifts and operating tables and so forth, for patients at the higher end of the BMI scale. And you can also see what the percentage of the procedures are as a function of BMI. All right, so in broad, what happens, you've got a registration process, which is relatively rapid. Then there's some pre-op, and then there's anesthesia, evaluation, consent, and then the sedation. We're going to lump these 2 together in our simulation model. I should just say at the outset that the simulation model is a significant simplification of what actually happens in practice, and that is to sort of get it on one page, so to speak, in AnyLogic, and present it to a group of the size that we are. Really going after the details would get into the weeds and create a very complex model. So we've got a relatively simple characterization here. The times are likely at odds with times actually experienced in practice, and those of you who have experience in these kinds of surgical environments will quickly pick up on that. So the idea here is to explore improvements in this process, given the facts of the case, not necessarily to come in and do a massive rewrite of the facts of the case in line with your experience. All right, so the patient is now sedated. Lumping these together gives us a mean of 25 minutes. And then the standard deviation, because I've got two variable activities, there's a little bit of possible offset there, where one is shorter and they have this at offsetting. So the actual standard deviation of the combined pre-op and sedation is, I think, 7.07 minutes. Then we've got the procedure. This is based on the paper by Dr. Knoja, 100.71 minutes, average standard deviation of 8.09. Yeah, I get that from, let's see, from this table right here, just using these weights and these means and standard deviations, you're able to figure a weighted mean and a weighted standard deviation. And then there's a cleanup of the room. These numbers are going to look low to folks who work in these environments. We're saying we can get it done in 15 minutes. There's significant infection risk, and so you really need to go deep in the clean. But we're going to work with 15 minutes average and a 5-minute standard deviation. And then numbers are given here for the patient recovery and discharge, but we're not going to model it, so those are not going to be relevant to us. I'm going to take a look at this operating room setup, the surgical process, using 4 lenses. Does utilization matter? Does pooling matter? Does psychology matter? And see if we can come up with some recommendations that can help us get a better patient experience and maybe 6 surgeries in each of these OR suites. Okay, so there are some additional questions that the director is interested in. What type of process is this workflow? What's the flow time? Where are the bottlenecks? And are any of these proposed changes potentially in conflict with fostering DEI objectives? So you've got an analogic model and the how-to playlist, which you're currently watching. Okay, so I'd like to have a quick look at the model. And it sits right here. So on Canvas, just go back here, you will be able to download the model here or from the case document. And I want to spend a little bit of time going through this, but I think I'm going to bump this to the next clip so that we have some separation on that.